But when back in 2016, 2017 timeframe, we were seeing a lot of malpositioned PICC lines, whether they were coming in from the home setting or extended care facilities, where every time the dressing change took place and they were changing the adhesive securement device, the line was migrating out. And we were either needing to exchange the catheter or place a whole new catheter for the patient. So we were seeing that pretty frequently. We were also seeing, when we were doing rounds in the hospital on the patients in our facility, we were seeing sometimes maybe we left 3 centimeters external, but when we were rounding on the lines there had been a dressing change by a bedside nurse, there was now 1 centimeter instead of 3 external. So we were really concerned about infection prevention. So I took a chance and reached out to SecurAcath to evaluate it. I just felt like, you know, I couldn't let my fear overshadow. So pleasantly surprised that it was not painful. I happened to be the first one to place one on a very wide awake patient, which was very unnerving to me, because I was really hoping that I would have somebody who was asleep and I could put it in, you know, kind of get my own bearings without disturbing the patient very much. But the patient was wide awake. I explained everything to him, and I really, it was way better than I had expected. And he was able to give me feedback and basically said he didn't feel anything at all when I put it in. So, so we've since implemented it. That was 2017, and we implemented it, I think, by the end of 2017, and we have not had a central line associated bloodstream infection in any of the lines that our team has placed since June of 2017. So I know a lot of people were concerned about maybe related infections because of it, because it doesn't get changed, but we have not had any infections in any of the lines that we've placed. So very happy to report that. Looks like Erin, and I think she's out of California, said that they've been using it since it first came out. Currently training a couple nurses on their PICC team. There is a little bit of a learning curve. It's not terrible. I would say probably I placed 3 or 4 before I really felt comfortable. And a lot of it for me was kind of getting over that I really wasn't hurting people. I mean, we put in that introducer when we place a PICC, and that dilates the skin. That's way more uncomfortable than trying to put a SecurAcath in. So for myself, I had a couple challenging initial placements because I was so nervous about hurting someone. I did experience one time that I didn't get it deep enough. I didn't get into the subcutaneous space. And that was quite a learning experience for me, because then it really let me know, because I definitely didn't want to cause any soreness at the insertion site for patients. And if I did get it in adequately in that subcutaneous space, it was a lot more comfortable for the patient. And so it was a good learning thing for me.
I remember that look on your face when you did your first one and you asked the patient, how did it feel? And the patient said, I didn't feel anything. And you were like, yeah.
Yeah. And then plus, I think there were probably 5 or 6 people in the room besides the patient. So no pressure at all.
Pressure at all. It's always nerve-wracking when there's observers, unfortunately, or, extra folks in the room. Right. I know it sounds like all of us that are on the call right now, folks might drop in, but Erin, thanks for sharing that you're adding some new team members. Molly, why don't you show your technique for insertion, and maybe we can talk about some insertion tips and tricks. You know, Kathy may have some point of view too, working in peds. So we can all kind of share on insertion, since it seems like that's a good topic right now. And I apologize, I should have said this at the beginning. I am recording this session for future use, in case there's some you know, great clips we can use for future purposes. So I hope everybody's okay with the fact that we're recording.
Okay, can you show my block?
Yep, I will pin it for you. Into spotlight. There we go.
Awesome. So I'm just going to take this out initially. So so the SecurAcath is put in, it's inserted generally when you first place the line. So once the line is in and you have the amount of catheter external, you've got your tip. Well, most of the time, at least in our facility, we had tip confirmation because we use ECG technology. So once you get it to where you want it to be, then I like to flip the catheter away from me. And I use the catheter and my finger to kind of really help hold some tension on the skin. As I'm using my thumb, it's a little harder to show on this block, but on patient skin, it kind of stretches that opening where the insertion site is. And you can tell this from the very beginning when you first stick a patient or put the introducer in, if their skin is a little tighter than other patients, you know, if it's not the 90-year-old lady that has very soft, movable skin or whatever, you might need to use your dilator introducer and just open that space. I'm going to pull out a dilator here and just kind of show you what I do if the skin feels too tight. So apologize, I should have pulled that out ahead of time. But I'll just kind of show you what I do with that dilator.
And as you're saying that, Molly, I would say that, you know, the device itself is always 3 centimeters. So you need a minimum of 3 centimeters on the catheter's length. So if you're doing your pre-measurements, you're going to need that length that you would trim to include that 3 centimeters or accommodate those 3 centimeters.
Exactly. Thanks for sharing that, Laura. So we were using one of the picks that our team uses did have a reverse taper. So we were already allowing some accommodation for that reverse taper in relation to the vein diameter. So that wasn't a huge change for us because we did leave some external. But yes, you do want to add 3 centimeters to your measurement to accommodate the space for the SecurAcath because of the feet that are in the subcutaneous space. So once you get the catheter in, if the skin feels tight to you or difficult at all, I use the introducer and dilate the skin a little bit more just till you kind of feel it pop through that layer of skin. So, and then you take your SecurAcath, and what I did, particularly in the beginning when I was very new at this, I'd kind of open and close this a couple times before I tried to insert it, just because I wanted to make sure that I had a hold of it and that kind of thing. So what you want to do is once you're holding the skin taut and the catheter out of the way, you fold the SecurAcath, and I like to put I call it the toes, right down at the insertion site, and you kind of swoop down inside. And sorry, I hope you can see. Once you get down inside, you want to make sure that it's in that subcutaneous space, nice and deep, I guess is the best way to say it. And once you feel it's where you want it to be and you have it positioned the direction you want it to go, then you release it to engage those feet into the subcutaneous space. So if once you get that in, you decide, oh, I want it to kind of aim this way because of however the patient's arm is or that kind of thing, then you can just move the catheter out of the way, fold the wings, and then change the position in the subcutaneous space, and then re-engage the wings and put the catheter into the channel. Make sure that it is in that blue little ridge there before you put the lid on. and you make sure that this is sealed all the way around. The other thing that you need to do once you have put the lid on the SecurAcath is you want to make sure that it flushes and still gives blood return. I did have one instance where, I don't know, I guess I placed several and hadn't even thought about it. And this one particular day, I did not check blood return. And sure enough, that patient, I had pinched it with the SecurAcath lid and needed to go in, do a dressing change, and just fix that. It's much easier to prevent that by checking as soon as you put the lid on.
One other point on that, Molly, I would add is this catheter that you're working with is just a tube, but with our marked catheters, we want to make sure, especially in multi-lumen marked catheters, so double lumen, triple lumens, that the dots are aligned in the channel before we seal that lid and snap that lid on. If the dots are in alignment, then that means the lumens, the interior lumens, are also straight. So what we don't want to see is that we have a bit of a turn between the wings of the catheter and the insertion point, because if we have any kind of twisting or turning of the catheter, although maybe even naked to the eye, that could lead to interior lumen twisting, which can decrease blood flow and lead to faster rates of occlusion. So we don't want to see that twisting at the point of insertion. We want to see that that channel is nice and straight, that those dots are lined up, and that when we close our lid, like you said, you get your full flush and blood return immediately before you put your dressing on.
Yep.
Great points. Excellent.
So the other thing is then once it's in, then that's when we kind of clean all around it. The other thing is to make sure that before you put the dressing on, once you've cleaned all around it, I like to kind of hold it up a little bit and allow the cleanser to dry under the SecurAcath. Otherwise, that moisture is trapped under there. Did somebody say something?
Nope.
Oh, so because if that's laying right on the skin, that moisture can get trapped under there and not allow that chlorhexidine cleanser to dry, and it could cause a chemical burn or some type of discomfort to the patient. So really making sure that you're allowing that airflow under there before you lay it down to put the dressing on.
Great points. And then if you're using like a disc dressing, how would you apply that?
So if you're using a disc dressing, which I have to say, our facility does not use a disc dressing, so this is kind of new to me. I do have one of these CHG discs here. You need to make sure that the disc, the writing side is up, which this says, the patch is up. And you want to secure it around. And there is a slight angle to that SecurAcath, so it won't be pulling on the skin or anything like that with that disc underneath. And then just allow it to lay naturally. And then when you go to put the dressing on, it's not a saran wrap type of thing. We don't want to make it tight and make a tight seal, because that's, excuse me, as I open up a package. If you make it really tight and stretch the edges, it can then cause some tension blisters and even pressure of the SecurAcath and the disc onto the skin. So you definitely just want to lay it over, follow just the contour of the skin, and then secure it down and use the warmth of your hand to really help seal that. But definitely do not need to stretch it like you would with saran wrap or anything like that.
Yeah. And the only other thing I would mention is the wings of the catheter, the wings that in the past might have had a stat lock on them, need to be under that border of the dressing. Again, that's really, really important piece that we want to make sure everybody does consistently.
Yes, exactly. And I do have a couple pictures of that. So here's one picture where you can see for this particular patient, there's certainly more than 3 centimeters external. And we did kind of curve this into the side, but still continued to make sure that those suture wings were under the dressing, because this catheter is very soft and flexible. And if you do not get that under the dressing, I'll show you a picture of a catheter that got kinked because this had been outside of the dressing and twisted and actually stretched and became thin. When I went to the bedside, the nurse had said that it was not functioning very well. The pump kept occluding. And once I peeled the dressing back, I saw this catheter here where I'm assuming that somebody did a dressing change. They had come in from outside with this, and that catheter was all kinked, and it just has memory there. So that could have potentially fractured if the dressing had not been changed and reapplied over the insertion site, because this part is meant to be in the patient's body and be more vein friendly than these lumens and things on the outside of the dressing should be. So it is really important to make sure that you have those suture wings under the dressing. Here's another shot of one outside the dressing, and that catheter is just so soft and flexible that it could fracture, and we don't want to do that.
Yeah, it leads to more tension on the line, and if you stretch on that catheter, those tension forces during normal like infused connections and disconnections can put stretch on that catheter body. And if the wings where the weight is are adding to that tension and stretch, the outer diameter will shift below the grip forces of the SecurAcath. So we'll see stretching or migration. We don't want to see those migrations. So the most important way to ensure that that doesn't happen is to have those wings under the dressing in accompaniment with the SecurAcath.
Exactly. And I know that in the beginning, I was told that when I was learning about SecurAcath, and I can remember calling Laura. I was getting ready to take a pick out. And when I got the dressing off, I must have tugged on the catheter, but not thinking, oh, the SecurAcath is still on there. And when I tugged, it kind of slid through the SecurAcath. And I called Laura and I said, this is a piece of crap. It's not working. It's coming right through the SecurAcath. And she said, do you remember what I told you? As you pull on this, because it is polyurethane, it will stretch and get thinner and then slide through that channel if you pull hard enough. So that's the reason we really recommend the suture wings are under the dressing as well. So that was a learning experience for me. I mean, we all learn from our mistakes, and that was a mistake of mine. And luckily, Laura talked me off the ledge like she has many times before. It says one is home infusion, other outpatient clinic.
That would be us.
Yeah.
Everything.
Oh, okay.
That's my team all behind me. So
Yay, you guys.
we're everything, long-term care, mobile, acute. So we have the contracts with a lot of the hospitals and nursing homes and everything.
Awesome. Awesome. So do you see SecurAcath a lot in the facilities that you attend?
This is my partner, Jen Lemon. We were hoping to see more and more, especially with long-term care, because they keep coming back to the outpatient for us to replace them.
Yep.
So that's why, you know, Laura's presence here and kind of getting back out there in the market and pushing for these is amazing. Binghamton's using them a lot. Some of our areas are using them a lot, but we need to use them more.
Saratoga, right. Yeah, we've had some conversations with Glen Falls.
Yep. Rebecca's
well, and we could talk about setting up, you know, upstate to learn how to do it, or maybe a select group of folks to do it if you've got some challenging patients. There's actually a poster done out of Canada that was the situation. They had a post-acute care group. It was a community-based group that did all the outpatient infusions in Ontario, and they were seeing patients that basically had to have disruptions of therapy to get their lines replaced because their lines would migrate, or they'd get occluded, or a combination of the above. And so they'd end up sending them back for another line, And they actually did a cost justification on why they needed to add SecurAcath post-insertion. So that would be really interesting to see on the United States side, because again, social healthcare, US healthcare is a little bit different. Reimbursement's a little different, but there may be a way to look at the cost justification and the disruption of therapy that happens when you have to delay a patient that's in the community.
So it looks like Aaron had posted a comment that there's a member of the team that's inserting the entire length of the metal portion.
Oh, I can comment on that. So the depth of it, it can go as deep as it needs to. The curvatures on the feet are designed to move the anatomy out of the way. And Molly, maybe you can cue up that video, that ultrasound video. But what you can see here is there's little balls on the toes. And so that flexible memory metal will actually push any structures beyond the dermis out of the way. The dermis is thicker, the subcutaneous is a different density, but like vein walls are actually thicker. If you've ever had a needle that just wouldn't pierce that vein wall, those different tissue densities react differently. And nitinol is a memory metal, so it reacts differently to different tissues. And this is an ultrasound clip of SecurAcath under the skin, and you can see here, it's just below the dermal tissue. You want to make sure you're deep enough that the patient doesn't feel it, that you're below that dermis. So diving deep may vary from patient to patient. Obviously, with smaller patients or patients with a limited amount of tissue, you're not going to need to bury the legs, but you do want to make sure you go at least past the dermal tissue so that you're in that sub-Q tissue. And some people feel more confident pushing it all the way in, releasing, and then retracting. Once you've got them in and you know your feet are in, regardless of the depth of the legs, you want to make sure that you retract so that pretty much most of the legs are showing. What we don't want to see is that the legs are buried in the tissue, because what that can do is actually create issues with pressure injury of the plastic at the insertion site. So again, once we insert and we've released the legs in the position we want to retract and make sure as much of those legs are outside the patient. But if you've got a technique, Erin, that's working for you and you know your patients aren't experiencing pain, that's fine too. I'm not trying to change your technique, but there is nothing wrong with inserting what I call burying the leg technique either. So it's designed to accommodate both.
I know that I was hesitant to do that initially as well. And then I think it was probably patient number 9 that I did not get those feet all the way into the subcutaneous space. And so then I became one of those people that kind of buried it just to make sure. And then once I released, then I kind of pulled back to make sure that there wasn't a lot of the feet in the tissue. But I wanted to, after I saw just how uncomfortable that patient was just overnight, because I was back the next morning, that's all I needed to make sure I went a little bit deeper. And I haven't I know that we've placed about 3,800 PICC lines since 2017. So that's a lot of SecurAcaths, and haven't had issues when it comes to being too deep.
And the other thing too is, again, with having your ultrasound probe there at insertion, if we're worried about depth, we can use the ultrasound to make sure we know where it is and that it's sitting right there. We want it just below the dermis, in that sub-Q space, not in the dermal tissue and not so far deep that it's, irritating or agitating any other structure. We've never had reports of it penetrating a vessel or damaging any other tissues. We have had reports of pressure injury and erosion due to being too shallow, and we don't want to see that. So that's why we encourage, again, ensuring that that it's properly below the depth of the dermis.
And I'm just sharing a picture that Laura had shared with me early on. And I pull it up a lot when we've had new members on our team, just to kind of show them. I believe this is an electron microscope image of the SecurAcath.
It's a 10x microscope.
Okay. And then this is a nitinol wire that we would be putting into a patient, maybe through the needle for placement. So it's definitely much smoother and polished, and I think of it as vein friendly and skin friendly. But that to me was really good to see it up close and know that there wasn't sharp edges and stuff on it.
Right. And Erin, your feedback is accurate. It is only 1 millimeter in thickness in the circumference around each end of the foot. But from the curve here at the T to the orange base, it's 1 full centimeter. And from ball to ball, it's 1 full centimeter. So again, this is the whole device from tip to from the T to the base is 3 centimeters in length. And these should always be, from around the curvature. You're right, that whole like curve there is 2 millimeters. So you do want to see that sitting below the dermis. It's very precise in its measurements.
Laura, this is Kathy. I have a question about that. What Erin was saying about protected patients. Do you recommend still using the SecurAcath on those kiddos that have no fat tissue at all?
I think it's patient specific and risk factor specific. We've gotten feedback where there's some patients that are extremely cachectic that I think that they're just more sensitive because there isn't a lot of subcutaneous tissue. Pressure is usually the causation there. Like we're seeing too much pressure on their limited, so you've got bone and skin and there's not much in between. And so you're sticking, again, just a couple millimeters of plastic in metal. I mean, the catheter's got to reside in that same pathway, right? But we're adding 1 millimeter to that pathway. Again, the thickness of the foot is 1 millimeter. So what I would say is weigh the risks and benefits. If the patient's very uncomfortable, you're in comfort care position and the duration isn't very long, the risk of dislodgement isn't high, then you make that decision. But if you need this line for a really long duration, you might want to consider the pain and suffering that might happen if they have a dislodgement and have to go through another procedure. So we know that the risk of dislodgement is quite high on a typical line. Somewhere between 12 and 15% of lines get dislodged during the course of care. So again, if you think about it as your family member, what would you choose for them? There may be trade-offs. If they're extremely cachectic and you're concerned about it, the other thing to do and consider, especially in some of your smaller, we see this in neonates a lot because of the patient size, the patient habitus, the surface between the bone structures like on the chest or in the arm and leg, and the way that the SecurAcath is lying, to put something between the base of the SecurAcath to create a little bit more angle. And so that way, that those feet are at the proper depth. And again, in a cachectic patient, now that we've talked about ultrasound these last few weeks, it seems only logical to use the ultrasound to make sure you're in that proper depth. Because I think, again, why we've seen more, I wouldn't say we've seen more issues there, but why we could see an issue there is because we don't have a lot of tissue, so it feels differently on that initial insertion. So again, I would use your clinical tools, use your clinical judgment, and make the best decision for your patient. But it's that same cachectic patient that has only their skin to protect them is not going to want to get a MARSI or some other, risks along the way.
I had a little 3-year-old that was 9 pounds.
Oof.
Yeah, and her leg length was normal 3-year-old leg length, but she only weighed 9 pounds, and it's like, oh, I just didn't feel comfortable putting it in there. I mean, like, you barely needed an ultrasound to hit her femoral vein,
Right.
Nothing.
But the ultrasound, not to necessarily find your vein and target it, but the ultrasound can act as a different tool to give you visuality to all the other structures and depths, right? So
Just using like her femoral vein was just
pulsing, I know.
One skin cell below the.
But again, I highlight the fact that that's such a great tool. Ultrasound tells us so much. Even when we don't necessarily need it to visualize, it can give us a lot of information. So, but yeah, this is all great conversation. I appreciate that. Yeah, I agree with you, Erin. You don't need to bury the legs on every patient. The cachectic one would probably be one where you feel it, use ultrasound maybe to help make sure your depth is proper. And again, those that are more experienced don't need to necessarily, you just know it's in the right place. There's a tactile response that you get, that feeling. And again, there's regional differences. So different areas, the bigger, fluffier patients, you want to make sure you're getting past that connective tissue so that you are in that proper sub tissue depth. I'm going to shut
sharing because we do neonates like, I don't know, micro preemies and preemies, but we don't have a lot of pediatric patients at our facility. So we either do the neonates that are 1.9 French catheters as the biggest, so we don't use SecurAcath, or then we have adults. So I'm not as familiar with the pediatric population. So it's interesting to get your perspective.
I do have a question for all of you. For removal of SecurAcath, do you guys all remove your lines with SecurAcath, or do your floor staff do it? Because that's one of the biggest issues we have here.
So in our facility, the floor staff would remove it. And if, unfortunately, just because of the pandemic and the changes in staffing, we have had a huge influx of new nurses or travel nurses that maybe haven't been trained on it. So at least in our facility, when I was there, they knew that they could reach out to the vascular access team if they had any issues at all. If they'd never seen SecurAcath, then they would get their charge nurse. If their charge nurse wasn't familiar, because there's times that they're all new, then they could reach out to the vascular access team. And we would come and walk them through it and do training with them. But yeah, primarily the bedside staff would be the ones to remove it.
I know I've talked to Laura about this before, because we've had some issues with that. We've had some kids that have come to the ER because home health has removed them or tried to remove them and had never been trained on how to remove them. And then you come in with this child that's been, pretty traumatized because now their arm is really edematous and, in bad shape. And it's because they've been trying to pull this thing out without bending.
Right.
Or even some of our nurses on the floor. So we've had several incidents, and so our CNO has required that we have a written competency for that. And so
that's great.
That's hard to keep up because
right.
a lot of the floors don't have that many PICC lines. And so if you just happen to be on the day that somebody's getting one removed, you might see them. But to keep a group of nurses competent on it is hard, to check them off and have enough opportunities for them to remove them with somebody. And then, so we've had trouble with that. And I was just curious if you guys all have written competencies here for the vascular access team. But, we're way smaller. We don't do 3,800 PICC lines. We do about 500 or 600 a year. So
this is 3,800 since 2017, not in a year's time. So
okay. Well, way smaller volume than what most adult people do. So I think they have more opportunities. Now there's some of our floors, like our CF population, that floor sees a lot of PICC lines. So we're able to get some of those charge nurses and checked off on removal of SecurAcath. But then a lot of the other floors don't have them, but every now and then, and if we're swamped, they may have to wait 6 hours before we can get there to take it out. So
it's a unique situation with SecurAcath because it's not something you're doing repetitively. And as you mentioned, like different areas of the hospital will have different exposures. So any type of practical skill, tactile skill, from an adult learning principles perspective, requires that repetition for maintaining competency and frequency. There's like a magic formula of how often you do something and how frequently you do it. So how many times you've done it and how frequently. And if you don't do it very frequently, you need to do it more. And if you do it frequently, you can get away with that learning curve in a shorter period of time. With that said, SecurAcath isn't removed every day, and it's not even removed at every dressing change like some other products, right? So I think that super user model is the way to go, especially with that lack of frequency and discussion of, you know, establishing. I think the competency is a great idea, because again, if somebody's not competent, there's accountability to that, but knowing where the resources are. So maybe not just having the competency be the actual ability to do the skill, but to know what to do. So watch the video, practice on the pad, then go into the room, so that you've got the mechanics down on the simulator before walking into the patient's room. When we help people in the field, you know, in the community on the hotline all the time, and the first time they're seeing it is when they call us. So it's not that it's difficult, but it's the nurse that attempts to do something without any information that causes the most, you know, disruption to the patient's experience. And we can do better. Like, we should all do better. The resources are there. The videos are there. I know our data tells us that nurses that have never seen it before that watch the video have a 99% success rate. And we track that based on the hotline calls. We ask the question, is this your first time removing it? Yes. Have you ever watched our videos? No. Can I send you the video? Yes. So we have all this data and as part of our algorithm for how we manage those calls. And it gives me confidence that the resources work if they're utilized. So that's, you know, that's not to say you haven't tried, Kathy. I know you have, but maybe what we can do too is meet with some of your nursing educators and administrators and help them understand the library of tools that are available and how best to apply them. We're also working on the pediatric aspect of the nuances in pediatrics. And I think once we have that, package that you've been a part of helping us orchestrate is going to be, I think, a good part of our future too, when it comes to supporting the needs in pediatrics.
Well, and I think that this need for education is far beyond SecurAcath. I mean, this is peripheral IV starts, port access, removing central lines, things like that, you know, because of the turnover of nurses, maybe they've never done it since they maybe got checked off in orientation or something. So that we're seeing that quite a lot, at least at the facility that I just left. They're not doing it on an annual basis to ensure these nurses are competent. And I think that we also have to put it on the nurses to own their practice and look this kind of stuff up and ask for education, and not just think somebody else will do it for them.
Same here, Molly. We have, you know, people that don't access a Metaport for 3 years, and so then they don't feel comfortable with it, so they're calling us, you know.
Right.
And the same thing with TPA. You know, when you're doing TPA in lines, especially when you're talking about a 1 kilo kid, you don't want somebody that's not that doesn't understand what TPA is and how much you're supposed to put in those little 1.9 French lines. So yeah, we struggle with that with TPA, Medport, SecurAcath, all that stuff too.
Multiple things. And I think that our clinical, I don't know how robust your clinical education department is, but it's hard to keep up with all of that stuff, in addition to all of the little checks and balances that have to be done on other things. It amazes me that, at least in our facility, it's a 4-hour training every year to check people off on the point of care finger stick for blood sugars. 4 hours for a finger stick, but we're not making sure that nurses can start an IV accurately, or adequately, or proficiently, whatever the word would be. So I think that is a huge problem in healthcare right now.
Since we just have 7 people on here, I'll go ahead and interject since we're talking about PIVs. We got a call for one for an infiltration a couple of days ago, and our nurse lived there, and it was actually inserted backwards in the hand. Backwards, going towards the tips of the fingers.
Yeah. And how the heck did they get it in that way? That's the other amazing thing. I have seen that a few times. we just got called to the emergency room to access or look at a port that was very painful. And the ER nurse had used an IO needle to access the port.
Yeah, for
So no drill, but used the IO needle itself. So
what kind of damage that did to the diaphragm?
the patient ended up going comfort. So they didn't do the dye study that we had recommended. But I can only imagine.
Wow.
So I think there's a huge need for education and current education, because I think that our clinical education departments, some of these nurses have been nurses a long time, and maybe they're not staying up to date. And I think that that's where a vascular access specialist should really be collaborating with education departments as well, to make sure that they're teaching the most current practice. And things like SecurAcath are current practice. I mean, it's shown, the evidence has shown that it's far more successful than sutures or adhesive securement device. So we need to be getting that information out there. There's a lot that needs to be done still.
Other topics, questions? Jan, I know you got some folks with you. Anybody on your side have any questions? You can post in the chat if that's easier.
No, I think we're good here. We're just excited that Molly went through everything and, regarding the insertion, because we definitely want to move forward with that. So, yeah.
And like I said, we have placed almost 3,800 PICC lines since we started, PICCs and midlines, because we use them for both, since we started using this in 2017. Now, there have been a few cases, if the patient is, Kathy, you brought up a great point with being very cachectic or whatever. And maybe we know, like Laura had described, that, their comfort measures, we just wanted to make sure that they had adequate access, and they probably weren't going to survive more than a week and really weren't moving around, then we didn't use SecurAcath. If we knew they were going to go home for 5 more days of maybe IV Rosefin or something like that, we may not, depending on the patient and how alert and oriented and things like that, we may not use SecurAcath. But it really has reduced, and I wish that we had numbers to compare before and after, but we really did reduce the number of lines that we had to replace. And we were very happy to know that we weren't causing or increasing infection risk. With SecurAcath, we've been able to maintain 0 infection rate in any of our lines that our team has placed. Welcome, Jacob. Maybe you can type in the chat where you're from and if you've had any experience with inserting or removing SecurAcath.
Or if you have any questions.
Yeah. So it is drop-in, not to put you on the spot, but.
Molly, since we talked about placement while we're waiting, if Jacob posts the question, maybe you could show us your technique for removal and how do you avert having discomfort during removal?
Good question. So things that I do for removal, let me make sure.
I'm going to put your other screen as the primary.
Okay.
There you go.
So things that I do for removal, our particular facility uses a dressing that has the chlorhexidine gel, which is somewhat of a challenge to get off of the SecurAcath. So it's definitely follow your manufacturer's instructions on removal. If the patient, so you kind of have to know your patient too. If you know that they're kind of overly sensitive to things, there's some patients that as soon as you touch them, those nervous Nellies, that you might want to, sometimes I'll bring in just a little baggie of ice and put a washcloth and ice over the site, let it sit there for a little bit, just for for their confidence that it's not going to be uncomfortable. And just that reassurance with them that you've done this before, that, you know, the experience of other patients, things like that. But removing the dressing, definitely using some kind of adhesive remover, whether it's just sterile saline. Some people use alcohol, which can be very drying on the skin. You can also use an adhesive remover like Detach-All to loosen that and get the dressing off. Because I'm on this pad, I'm just going to kind of pull it off. I would never do this on a patient, just kind of rip it off, because we don't want to remove skin cells.
Detach-All, this is where you would use your Detach-All, right?
Yes, yes, Detach-All for here. But I, for the sake of time, am pulling that off.
And focus on SecurAcath. I appreciate that.
Yes, and removing the patch. I like to look at the site, just see what it looks like. Certainly I know how long the line is before I go to remove it. And I will remove the lid on the SecurAcath. So you hold over here and lift the lid. The thing that I do first when I'm removing a PICC line or a midline with SecurAcath is I like to remove the catheter first. That's a personal preference of mine. I just feel like it gets that out and gets it out of the way of the SecurAcath. It gives me a little bit more control. So then I've gotten my gauze and my either my antimicrobial ointment or some Vaseline gauze over the insertion site, and I remove the catheter. So once the catheter is removed, I just get hemostasis. And usually at that point, we use antimicrobial ointment at the insertion site. So that's also kind of softening the skin a little bit as well. If you notice before you take the dressing off, or once you get the dressing off, that there seems to be a lot of granulation tissue there, then I will take some sterile gauze with some saline and let it sit there and soften that as I'm holding the insertion site, just to kind of soften up that granulation tissue. Some patients tend to, patients get keloids sometimes, not so much. I don't see it a ton with SecurAcath, but some patients have more hypergranulation than others. So really, just softening that skin and letting the patient know what's going on. So then at this point, once I've achieved hemostasis, and I usually still have my gauze or something here, I will really hold tension on the skin, which is kind of difficult to see on here, but kind of like when we inserted it, making sure that we're kind of stretching the opening so that this comes out much easier. So I very rarely will cut the catheter or cut the SecurAcath. So at this point, as I'm holding tension, I will go ahead and fold this in half and keep it kind of parallel with the skin.
Your pointer finger on the blue is very important. I was going to call that out. It looks like
I was just going to say, and I have my pointer finger here on the blue line because that just gives me a lot more control. I kind of choke up on it a little bit, hold it close down so that I have more control over it, and really holding tight down here on, just so you can see, but right at the insertion site, and kind of stretching that open. And you want to kind of pull up and out, kind of like deaccessing a port. And you definitely want to remove with intention. If you hesitate, sometimes it can catch just a little bit. And I know for myself, being the chicken that I am, if I felt like it was catching and I was new at it, I might stop, and that could cause discomfort. So really that pulling up and out, making sure that the keeping that parallel to the skin, so that those toes are still pointing down and not sideways or anything like that in the tissue. If you want to cut the catheter, I've got one here that's pre-cut. You definitely would need to get some sterile scissors and cut that. It is quite challenging. You really have to cut it with intention because we don't want that to break with the multiple dressing changes and things like that. So it is quite a challenge at first, the first time you go to cut it, just to kind of get the feel of how that cuts out of there. And so at that point, once they're cut, you want to aim the little wings down and hold and pull up. Well, I just put these in together. So, but definitely put the wing down so that the toes are down and it pulls up and out very easily. And the same with the other side. So just making sure you turn it with the wings down. You don't want to have it to the wings to the side so that the toes catching on the skin. So wings down, pull tension on the skin and pull up and out to get that out.
And Molly, there's one more cut version, which Matt Gibson has kindly called the ninja move. And that's where you feel the foot and prolapse the foot under the skin. So that's if it's really embedded, you want to hold your finger over that foot and prolapse it. Could you demonstrate that with one of the cut ends?
You know, that sounds great.
Kind of hold it upright. Yep. Hold it upright, like almost perpendicular. And now feel for the foot underneath. And then you're going to prolapse it. So you keep your finger right over it and then you're going to straighten it out.
Kind of then straightens.
Yeah.
Like that. Okay. That's a new one for me.
Now that's when it's really tough, like it's not coming out the insertion site, and in that prolapsing, it's designed to literally like allow the foot to bend out, and holding that tension right over it straightens that foot out.
So, and this will flex with the skin. I've, in all of the lines that I've removed, I've only had difficulty with one. And
that's a lot. I mean, one is not a lot. It's the many you've removed relatively.
Yes, I've removed a lot. And so I called the 800 number just to reinforce kind of things that I should do, because I hadn't come across that in all of the years that I'd been putting these in and taking them out. So just know those resources are available to you whenever you call.
Despite your level of experience. So even years later.
Yeah. I mean, we started this in 2017, and this was probably, I think it was the fall of 2022 that I had a challenge with a patient. And the patient was wide awake and alert and oriented. I was so worried that I would be hurting him, and he didn't, even with me pulling around on it, he didn't complain of any discomfort at all. So I was pleasantly surprised, because I would be a mess if it were me, because I'm a chicken. And I guess maybe we scared Jacob because he left.
I know there's another person, name on the screen is N. Gibson. I didn't know if you have any questions or want to post any questions, any topics you want us to cover.
Yeah, because this is kind of interactive. We didn't really have a huge script set up for you guys, just wanted to be able to answer any questions or concerns that you might have in using SecurAcath.
Other tips and tricks for removal would be to saline soak the insertion site.
Yes, and sterile gauze.
Or using sterile saline. We talked about cooled sterile saline and on a different call one time. Kathy, got any other tips and tricks? I think you mentioned Buzzy Bee in the past.
Yeah, on our kids, we will sometimes use Buzzy, which is a vibration device that's supposed to interrupt your relay to your brain. We use it for IV starts and anything painful, immunizations and stuff like that. We can use Buzzy, and sometimes I'll spray a little bit of cold spray as I'm removing the bottom part of the SecurAcath. You can't spray it very long because it will freeze those little metal feet, but if you just spray it just a few seconds, it helps a lot on removing it on those kids that are kind of anxious. And then we always call the top of it the orange turtle shell, because that makes sense to the kids.
Yeah.
I love that.
Yeah. That's awesome for kids. And know your population. I know that I'm a gabber, and I feel like really distracting patients, talking with them about what's going on in their life or whatever. If they talk about having grandkids or whatever, then I kind of engage them in that type of conversation as I'm doing this. And usually they find that it's out before they've even realized I've done anything, because I've distracted them with conversation. And generally it's not a huge issue at all to remove this. So the other thing that I wanted to mention, and do you mind switching me back over, because I was going to share one of the things that I had seen. If somebody has pretty thick arms, I will position the catheter. I'm going to make this a little bit smaller. I will position the catheter so that it falls behind the AC. Just sometimes nurses really want to keep everything in such a straight line, and here's one picture. So you can kind of see the insertion of this SecurAcath. So if this would have been in a straight line, it would have gone down this way. And so as the patient bends their arm, then it can cause this to kind of push on the suture wings. And depending on how much tissue is in their upper arm, it can cause pressure and just irritation from that. So we typically try to either turn it to above the AC, or if their arms are really thick, I will put it below the AC, so that when they bend their arm, it just drops and doesn't get caught up in the tissue and cause pressure and kinking and anything like that. I might have a couple other pictures here. So this one, you can kind of see this one's in a straight line. And so this is secured right at the AC. So if that patient moves their arm around, this catheter is going to kink right here. And so instead, this is not the greatest picture because there's a lot of discoloration. Hold on, let me move this off of the, I don't know if that's showing up, the pole's showing up on your screen. But this is secured so that it falls back when the patient bends their arm and is not in any way affected by the movement of their arm. We don't want patients to hold their arm and not move around.
And that's also in line with the ZIM methodology of the zone insertion, of finding the middle third of the arm and having your exit site in that middle third. So if your optimal vein selection is higher or lower, finding a way to make sure that you get your exit site in that green zone. So excellent.
So Laura, are you seeing this whole box on my screen?
I am.
I can't make it go away.
Oh, you want to stop sharing?
The poll.
Oh, I took the poll away.
Oh, I'm seeing it on my screen. So I was worried it was showing up on yours.
Yeah, no, it's not. Sorry. When you were pointing it, the mouse is moving over the pictures.
Okay, great. Yeah, so I'm seeing the poll over my pictures. So
you should be able to close that window. There should be a red button on it.
I'm trying to think what else I have here. I did put some pictures of.
I see we have another person from Cook Children's who joined us, Stacy Bancroft, who's an educator. Thanks, Stacy, for joining us. If you have any questions or anything that you'd love to hear, or topics you want us to discuss, let us know. It's an open forum, so we're just kind of sharing.
So this is just a picture of a chemical burn that we had seen with a patient that they did not allow the chlorhexidine to dry completely before they put the dressing on, and it caused a lot of little blisters. And if you can kind of see here, and I didn't get a picture of the site underneath the SecurAcath, but there was a definite imprint or redness related to the SecurAcath because of the moisture that wasn't allowed to dry under the SecurAcath. So that's why it's so important to allow that chlorhexidine to dry. I think that the package instructions for use for chlorhexidine is maybe 30 seconds, but it's very patient specific. Sometimes their skin takes a little longer to dry.
Oh my gosh, I finally got through the stupid orders. Did it?
Oh,
Got it.
somebody. Okay, so definitely make sure that the skin is dry before you do the next steps, whether you put skin protectant on there, if you put some mastisol, allow each of those layers of cleanser and dressing preparation to dry before you put the dressing on, because once this happens, this particular patient, we ended up cleaning the site with no chemicals at all. We just used sterile saline and gauze, and we did a gauze dressing. Let's see if I've got that here. We did a gauze dressing and changed it every 48 hours until the skin healed. Because every time you clean this just becomes a vicious cycle and it gets worse and worse. If you clean this with chlorhexidine and then allow it to dry adequately, after this has already taken place, you're just exacerbating the problem and needing to take the dressing on and off and continuing to perpetuate this problem. So really, definitely just cleaning this with sterile saline, allowing it to dry, use a gauze dressing, and then we would use just some Curlex or something to wrap around their arm, and then a stockinette to hold it in place. And we would have them come back every 48 hours to do a dressing change, unless it wasn't lasting for 48 hours. This particular patient was able to finish their therapy, and luckily for them that they did have a SecurAcath, because an adhesive securement device would have really been a challenge with skin breakdown like this from the irritation from the chlorhexidine. So I don't know if any of you guys on the call have had irritation, and a lot of times people will say, oh, they're allergic to chlorhexidine, or they're allergic to the dressing. And there's really no way to tell that for sure as far as a true allergy without being tested. But a lot of times it's just because the clinician didn't allow the cleanser to dry before they put the dressing on.
Yeah, and I think you made a great point. One thing I usually show and teach is because there's different temperatures, moistures, air variation, skin condition that can, play a role in how long something takes to dry. As they finish that step with that wand or swab stick, to touch the back of their glove and watch their glove dry, because the nitrile glove will take the longest. And if it's the last thing they do, they can watch that dry completely before they move on to the next step.
Right, for sure. I thought I had a really good picture of.
And while you're looking for your picture, Molly, I posted a coloring book that we made for pediatrics. Kathy, I thought you'd like that. It's a PDF that I attached in the chat section. So
I saw that, but I can't get it to click on. I tried to click on it.
Oh, it won't download. Oh,
I can't get it to download. It keeps looking for another file. Send it to me in an email.
I will email it to you.
I dress up as a SecurAcath for Halloween. We do a Halloween show here, and everybody was going to dress up as different things. Like one of my staff was going to be the diva and have a buff and dressings and stuff like that. But I don't have enough silly people that will participate. So.
Well, I can't find the dressing that we use, but I also wanted to show this picture. I think that Laura had shared this with me. I had a couple nurses when we first started using SecurAcath that were concerned about causing tissue damage or discomfort, or you know, the challenge of, is the SecurAcath 100% effective in securing the line? Well, you and I we all know that patients can pull out a Foley catheter with the balloon fully inflated, and it makes me hurt just thinking about. So it is a possibility with the SecurAcath as well. And so this is actually an image of a SecurAcath or a PICC line that was removed with the SecurAcath intact. But I do have a picture of the skin afterwards. And I think some of the bruising was from, it looks like the patient had a couple attempts on the insertion, but really the site was not too much trauma was going on in the skin at the site because of that SecurAcath coming out. So I think it's just a nice reinforcement that those feet, those nitinol feet, will kind of bend and come out if pulled hard enough. Like I said, just like a Foley catheter with the balloon fully inflated can come out of the skin, out of the.
And it is designed to prolapse under the right amount of pressure safely. So 4 sutures are about the equivalent. So if somebody had thrown, you know, 4 sutures through the skin, 2 loops each, 8 extra holes in the patient, then that's the amount of pressure. If you rip those through the skin, it's an equivalent pressure. So when it was designed to be able to tolerate a forceful pull on the actual device, on the actual base. But as we talked about earlier, more likely the tension's on the catheter body and on the wings of the catheter, and that would stretch the catheter if it's not properly dressed.
So I did have an instance where a patient had pulled on his catheter, his PICC line, the catheter fractured outside of the dressing, and luckily the catheter body itself was still inside the SecurAcath, holding it safely. It happened, we don't have a 24/7 service, so when we came in on day shift, the nurses were all afraid to even touch it. And when I got in there, I was like, awesome, that SecurAcath really hung on to that line and kept it in place so that we could take it out safely.
I always learn something every single time I come to one of these SecurAcath. And it's just amazing, just the points that we can pick up here. So I just want to thank you over and over again, because we're excited in Syracuse to start moving forward.
Awesome.
Thank you, Jan.
Yeah.
Appreciate
Thank you.
I have a little folder here of all kinds of things that I wanted to, I guess we've talked a lot about PICCs and midlines, but we do, our team just started placing central lines before I left. And so we were using SecurAcath to secure IJs.
Look how pretty that looks.
I know. Oops. My coworker Nancy placed this. This was the very first central line placed at our facility by a nurse. So low on the neck and getting in there. We've had some hospitalists who were really interested in using SecurAcath. But it's really taking it away from the ear and securing it down onto the clavicle area, or down kind of this way, depending. So getting it away from the whiskers as much as possible. This picture would have been more ideal if they would have trimmed his hair more. But really taking it away from the ear where we see it a lot. I had one patient.
I was gonna say, if you turned that one up, you wouldn't have had, it would have been covered. Even if you trimmed it, it would have been grown back the next day.
Right.
So
yeah, I had a little lady that it was sutured right by her earlobe. It was crazy. So
yeah, I hate the ones of the little old lady. And I saw one that somebody sutured it like to her cheek. I was like, what are you doing?
Yep. So and really, you know, I think just making sure that we're not putting it straight in a line, because yeah, it's above the arm, are above the bin, but if you tape this and secure this down, this happens to have just an adhesive securement, but we want to prevent the line kinking and getting pushed in and out by the arm movement and causing irritation. I've had a couple patients in the 6 years that we've been using it who've had a history of nickel allergy, and majority of them have not had trouble with SecurAcath irritating them at all. And I've had a couple people that have just had like a little bit of itching and just a little bit of redness around the insertion site. And then when I'll question them about sensitivity to cheap jewelry, things like that, not that SecurAcath is cheap, but there is a lot of nickel in that cheaper jewelry. And so if they have itching or just a little bit of irritation right at that insertion site, and there's not, and it's been from insertion, then we have removed the SecurAcath without any issues at all. But we have, when we know that they do have a nickel allergy, we just discuss it with them and explain to them that that doesn't necessarily mean they're going to have a problem with SecurAcath. And we can easily take it out if they do have any discomfort with it at all. And so I would say I've probably, in all of the lines that we've put in, probably removed, I don't know, maybe 10 in all of that time that I can think of, because of irritation. Seems like I notice it more with pregnant moms. I don't know if they're more sensitive, but it seems like that if I am gonna have to take one out, it tends to be those hyperemesis moms. I don't know why. I don't have the data to support that, but it's just what sticks in my head.
Yeah. Well, there is some studies showing that hyperemesis has got a genetic component to it, like that women are inclined or not inclined. So it's interesting.
So it just kind of depends.
Very interesting.
We have right now, I deal a lot with the Lyme population, and they're having a multitude of skin problems. As Molly was showing, a lot of the burning on the skin, some type of hypersensitivity they have. We have to be extremely proactive with utilizing our high performance dressing with that population. And that was not the case, but now, you know, putting in these lines, at least daily for Lyme, for the ceftriaxone. We are very proactive with that high performance dressing right from the start. So we're setting that stage with the gum mastic and everything that we need. So,
Awesome. So the gum mastic seems to help with that as well.
yes. Yes.
So do you guys then have the adhesive remover that works well with that, the detach-all to?
We have detach-all, and we also have Unisolve.
Okay.
Unisolve is a little bit more moist when you're using the prep area, you know, so we have to allow that to dry for quite some time. The detach-all seems to have a quicker drying time.
And I think that it's more, from what I've read, it's a little more skin friendly than some of the other substances because of the alcohol content.
It's alcohol free and acetone free. So yeah, it's going to be a lot gentler on the skin, but without all those annoying scents either that you'll see in some of the others.
Yeah.
So I guess Mastisol might make up for that, for the scent.
But I liked what you said, Molly, about, you know, the acrylics and wrapping and doing the gauze dressing, you know, just to support it, because we've been doing a lot of that. But in the home care situation, we definitely have to send the nurse out every other day, which can be complicated or challenging.
Yeah, so we were seeing them come into our outpatient infusion center, and our team would do the dressing changes for them. But in the home setting, I think it would be challenging I think
Mhm.
that
Yeah.
there is a huge need to really share education with our colleagues in the home care setting and the outpatient infusion setting, to try to, you know, to just make sure they're all up to date on the best practice when it comes to this kind of stuff.
And getting approval to go into the patient's home because we have to qualify it through this CMN in order to go to their house every other day. And then who's going to pay because insurance only pays for one visit per week for labs and dressing change. So we have to get another prior authorization
Right.
for additional
Visits.
visits if needed.
Mhm. Right. But if you're preventing infection, seems like
Hmm. Yeah.
Yeah, it's insurance. Love it.
they dictate.
I've been dealing with my own family pre-authorization nightmares. So ugh, I can only imagine if you just needed a dressing change. And it
Right.
happens. I mean, the studies show us that the dressings, without mastosol, without the proper technique, don't last 7 days. And they can't see you for 7 days. I can't imagine that how often you have to sit there, the administrative hours you have to put into that. I mean, it's stressful.
Well,
Mhm.
and then so some patients will then put extra tape on. I've seen some patients come from the outpatient setting with duct tape on the edges. And it's,
Electrical tape, everything.
yeah, it's just like, what kind of damage
Thanks.
are we doing to the skin as opposed to getting the care that they need when they need it?
Mm. Yeah, the skin is the most important as soon as we put those PICC lines in. I always say, set that foundation, set that stage. Because I feel a lot of times it starts right with the insertion. And if we can keep it nice, because it's the very first dressing, it's the very first thing that goes on. And I very sensitive about that.
I'm right there with
No
you. I'm
pun
a rule follower when it
intended.
comes to that.
Yeah.
So I like doing all the tips and tricks and having the gum
Mhm.
mask stick and
Yeah.
just SecurAcath, being able to not have to worry about that line going in and out.
Right.
Pressing change.
Dislodgement is so huge, going and then all of a sudden it's out so many centimeters and doing it over the wire or doing what we need to do to get that line replaced can be costly and also the patient. More
Right.
importantly, the patient.
Right.
More importantly,
night.
has to go through.
Yeah. I could talk
Thanks,
about
Kathy.
access all the time. So
Thank you. Well, thanks, Jan, for sticking in with us the whole time.
Oh, you're welcome. I had people in and out. Kathy just left. And so they were, came in when you were doing the removal and the
Good.
insertion. I wanted Zach, one of my other RNs, to come in when you were doing that. So it was great. It always is great.
This is always a fun session we do. Bye, Matt. Have a safe cross-country meet.
you, Matt.
Jan, I look forward to meeting you in person at Ava. Please stop by the SecurAcath, aka EloQuest booth, okay?
Oh, that's right. I forgot all about the Mastisol and Detachol. Oh my goodness. Of course, EloQuest.
Yeah, we'll be the belle of the ball again this year.
I'm seeing a little bit of your shirt right now. Oh,
Yeah.
we love Mastisol and
Awesome.
Detachol more than anything. I order it all the time. Now I need SecurAcath.
Yes.
Yes.
Yeah. Awesome. Well, thank you all, and I look forward to seeing you soon.
Likewise.
Bye. Thank you. Thanks, Jan. Thanks, Matt. Thanks,
Thank everybody.
See
I'll
ya.
talk to
Thank
you
you.
soon. Take care. Bye, Molly.
Bye.